So they have been kind enough to give me a topic which would be relevant. Hypertrophic cardiomyopathy is something easy to treat, and I'll stick to the management thing. Now to introduce me, I'm Dr. Priyank Mody. So consider me as a first year resident in medicine in Jamnagar. So I did my medicine from there. So first year medicine residency was going on, and we had an assistant professor, toxic guy, like sincere guy, but for residents they are toxic when they keep on coming and they keep on calling. So one of the non-emergencies day, I got a call from my fellow colleague whose emergency was going on that your boss has come to the emergency, run. So I said, like, this guy doesn't even want to rest. So we went to the emergency, and it was not my boss, it was my pulseless boss. And we gave CPR for 2.5 hours and still lost him. His name was Dr. Murtuza, if someone from Jamnagar is here, 15 years ago. And maybe post-mortem analysis was done, and it was found to be hypertrophic cardiomyopathy. So when as a physician in our own self we can miss something, it is high time that at least we get awake for our patients. Cardiomyopathy is defined as, they are the disorders characterized by morphologically and functionally abnormal myocardium in absence of any other disease which is sufficient to cause that kind of phenotype. And hypertrophic cardiomyopathy is the disease state in which there is left ventricular hypertrophy, but it is in absence of anything which would cause that left ventricular hypertrophy, whether it's hypertension, coronary artery disease, valvular artery disease, any systemic or metabolic cause. I have tried to get all the data from American College of Cardiology 2024 update so that we are at par with what's really happening in the world around. In the management part, there are 3 important aspects. See, you would, to manage a patient, first you have to suspect. You suspect that the patient has this disease, then you will evaluate and confirm your diagnosis. That's step 2, and the step 3 is treatment. So when would you suspect? The most common presentation is chest pain, palpitation, exertional dyspnea. Sometimes a patient would come to you for evaluation of syncope or pre-syncope. The history would be characteristic. He was running around or playing some sports, and then he had a blackout. To be frank, in my practice, the most common patients I'm seeing right now are pre-employment assessment and health checkups. A lot of young patients go for pre-employment assessment. They do an ECG there, and that ECG has left ventricular hypertrophy. The patient is not hypertensive, and then they send them these kind of patients to me. The second aspect, because we live in an era of government schemes in Gujarat, so a lot of patients are referred to me for angiograms for abnormal ECGs, and they have hypertrophic cardiomyopathy. So dyspnea on exertion is the most common symptom, 90% of the patients. Palpitation because of various arrhythmias which are common in hypertrophic cardiomyopathy. Congestive heart failure, particularly these are diastolic heart failure due to increased LV filling pressures. Angina do happen in hypertrophic cardiomyopathy, even in absence of coronary artery disease. We'll discuss that. As I said, syncope and pre-syncope are common. Pre-syncope and syncope will happen when the patient exerts. There is increased contractility during exercise, and that will reduce the cardiac output because it will increase the gradient. And whenever there is decreased preload, so if the patient is dehydrated or he is taking any form of medicines which would reduce your preload and afterload, and there might be arrhythmias which can cause syncope. So sudden cardiac death, as I said, is one of the most common, and sadly an initial presentation in a lot of patients where the patient is undiagnosed, and hypertrophic cardiomyopathy is the first presentation is sudden cardiac death. The most common cause is arrhythmia. To be frank, more than 30, in patients less than 35 years of age, if someone has sudden cardiac death, 1/3 of that patients, the diagnosis is unseen hypertrophic cardiomyopathy. Physical examination, carotid pulse will be bifid. The JVP A wave will be prominent because of reduced RV compliance. There will be double apical impulse. Heart sounds will be difficult to differentiate. Murmur is characteristic. It's a mid-pitch crescendo, decrescendo murmur. It's a systolic murmur, usually holosystolic. It is best at the left lower sternal border and the apex. Now, the biggest aspect about hypertrophic cardiomyopathy is the murmur will change according to some maneuvers which we can do. So, whenever we reduce the preload by Valsalva or standing, the murmur intensity would increase because the preload to the heart will reduce. If we increase the preload by squatting or hand grip, the murmur intensity will reduce. So, this dynamic variation helps us differentiate the murmur of hypertrophic cardiomyopathy from aortic stenosis. Different patterns, the most common being asymmetric septal hypertrophy, which we all know. Sometimes it may be non-obstructive. If there is significant hypertrophy, it will be obstructive. Another variant which is common is apical hypertrophy. Now, when you want to understand the symptoms and you want to plan the treatment, the basic thing you need to know is pathophysiology, because that pathophysiology will explain the symptoms, what's happening to the patient, and you will be able to reverse that pathophysiology with your treatment. So, in pathophysiology, left ventricular outflow obstruction is the most important aspect why patient develops hypertrophy symptoms. Diastolic dysfunction, it is heart failure with preserved EF kind of scenario. Mitral regurgitation, myocardial ischemia, and even autonomic dysfunction is known. We'll go fast here because I really want to concentrate on management, because I feel that I'll be able to put across certain things which will help you guys in managing hypertrophic cardiomyopathy. So, left ventricular outflow obstruction is the major problem. The reason why it happens is because of the thickened interventricular septum and systolic anterior motion of the mitral valve. So, what happens in systolic anterior motion? Because the interventricular septum is hypertrophied, the papillary muscles are disoriented, and that would push the anterior mitral leaflet towards the septum. And second, whenever blood goes from a narrow path at high pressures, it will create a negative pressure which will pull the mitral valve towards the interventricular septum through Venturi effect. So, one, the valve is pushed, and the other it is pulled, and that is the reason during mid-systole it would completely obstruct your LV outflow and there will be reduced cardiac output. Diastolic dysfunction contributes to 80% of the symptoms what the patient has. It is because of increased filling pressure. There will be increased pulmonary venous pressure, and that would cause patients exertional dyspnea and in severe cases orthopnea and PND. Myocardial ischemia will happen in without coronary artery disease because of demand-supply mismatch. The thickened myocardium requires more blood, and even if normal coronaries are there, they would not supply. Pathological analysis proved that in these substrate of patients, the intramural capillaries were reduced, and the overall number of capillaries according to the LV mass was less. Mitral regurgitation, as we just described, the most common cause is SAM, that causes mitral regurgitation. The second thing is intrinsic papillary muscle dysfunction. Now, once you suspect that these patients would have hypertrophic cardiomyopathy, what are the diagnostic tests you would like to do? So, ECG is basic and most common, because 70 to 90% of the patient who are phenotype positive. What do I mean by phenotype positive? Who have some form of hypertrophy where the LV wall thickness is more than 15 millimeter, they will have some ECG changes. So, ECG becomes one of the most sensitive screening tests. They will have left atrial enlargement, conduction abnormalities. Now, you can see this asymmetrical ST depression. So, if it is ischemic ST depression, it will be more symmetrical. Here it is more asymmetric. In this asymmetric septal hypertrophy, the ST depression will be in the enterolateral lead, so that is 1 AVL and V4 to V6. If it is apical HCM, your ST depression, deep ST dagger-like T waves will be there in the precordial leads like V1 to V4. Now, in which substrates of patients will you order Holter monitoring? So, if your patient is symptomatic, a patient is already labeled as hypertrophic cardiomyopathy, comes to your clinic, he tells, okay, sir, thoduk heartbeats feel થાય છે, થોડુંક light-headed લાગે છે when I'm walking. So, at that point of time, if there are symptoms which suggest any form of arrhythmia, you would order a Holter test. You can put up a 24-hour Holter or a loop recorder depending upon the symptoms. In which asymptomatic patient, so the patient of hypertrophic cardiomyopathy is in your follow-up, so The patient doesn't ask for any, doesn't tell any symptoms, but where would you order in an asymptomatic patient is where the baseline ECG has significant premature atrial beats or premature ventricular beats, some arrhythmias. You can do it as screening in high-risk phenotypes of sudden cardiac death. If the brother had a sudden cardiac death at 30 years of age and the younger brother also has a phenotype for hypertrophic cardiomyopathy, then you can order a Holter test to see for any non-sustained ventricular arrhythmias. Or any patient who has had high risk of development of atrial fibrillation, because if on echo the LA is enlarged, then these are subsets of patient you can order Holter monitoring. 2D echo I feel is the gold standard, or I feel it's the Achilles heel of hypertrophic cardiomyopathy. Guidelines recommend that a 2D echocardiography that should be done in all the patients of hypertrophic cardiomyopathy. Two important aspects to diagnose is end diastolic wall thickness more than 15 millimeter. And if the patient has symptoms, the gradient more than 50, and if the patient does not have symptoms, the gradient more than 30 are diagnostic of hypertrophic cardiomyopathy. If you yourself are doing a 2D echocardiography, if there are people here who do 2D echocardiography on a routine, I would like you to add certain aspects when you report a patient with hypertrophic cardiomyopathy. And once you establish the diagnosis of hypertrophic cardiomyopathy, help them determine the variant, whether it is asymmetric septal hypertrophy or apical or something else. Also look for certain, like what's the extent of hypertrophy. Give exact wall thickness in end diastole and end systole. Measure the severity of left ventricular outflow, not just at rest, but even after maneuvers, so dynamic assessment. Look for presence of systolic anterior motion. What is the diastolic function? What is the regurgitation, mitral regurgitation content? What is the LA size? And whether there is any LV aneurysm present or not. So these are the echo images. Now cardiac MRI, for me it is the gold standard in establishing diagnosis of hypertrophic cardiomyopathy. So when I say that you should get a cardiac MRI for all patients with hypertrophic cardiomyopathy, do the guidelines say the same? Then the answer is no. But cardiac MRI should be part of the initial evaluation in all patients if we can really get it. It has greatest importance in borderline patients. So patient has changes in the ECG where there is LV strain, but echo there is no wall thickness, or the echo windows are not very good, or members of high risk families who are genotype positive. So they were genes for HCM which were positive but phenotype negative. So it means that the echo did not show any thickness. Then in these subsets of patients you can add cardiac MRI. It also helps in evaluating or differentiating other causes of restrictive cardiomyopathy, because sometimes the thickness of the myocardium may be because of infiltrative disease like amyloidosis, or even in athletes who are into heavy exercise, they may have an hypertrophic myocardium. So these subsets of patient can be easily differentiated from hypertrophic cardiomyopathy with gadolinium contrast MRI. Late gadolinium enhancement is a wonderful test to know what is the extent of myocardial fibrosis. So if the extent of myocardial fibrosis is more than 15% in a cardiac MRI, these patients should be considered at high risk of sudden cardiac death, and they should go for an AICD. Other high risk features can be identified. What if the myocardial thickness is more than 30 millimeter? Presence of LV apical aneurysm, or presence of LV dysfunction, even a little bit of LV dysfunction where the EF is less than 50 in a patient with hypertrophic cardiomyopathy is a very high risk for sudden cardiac death. Genetic testing. Hypertrophic cardiomyopathy is an autosomal dominant disease, so there's a 50% chance that you will give it to your offspring. It is a disease of the sarcomere. There are two types of testing. So as I said, like one of my boss who died, so you do a postmortem analysis and you send the genetic assay. It's easier to send. Medgene is the company, they charge around 8 to 10,000 rupees. They do the whole panel testing for your index case. Now there are more than 450 genes, but two are the reason for 80% of the genetic cases. So one is MYH7 and MYP BP3C. Now these are the patients. So cascade testing is for relatives of the patients with hypertrophic cardiomyopathy. Exercise testing not contraindicated. You can do it. Previously when we were studying, we used to say we should not do an exercise stress test, but when the gradients are more than 100, contraindicated. More than 50, do not do it at clinicals, in clinics. Other patients, you can do it. I would like to go ahead with management. Can I take 5 minutes? Is that okay? Or
2 minutes.
2 minutes, okay. So management, because this is the most important aspect. Medical therapy, beta blockers. Now this is an important aspect. The beta blockers you should give in treatment of hypertrophic cardiomyopathy is non-vasodilatory. I've even seen prescriptions with cardiologists who give bisoprolol and nebivolol. So it is not just beta-1 selective, they have to be non-vasodilatory. So when you give bisoprolol, they have vasodilatory properties, and that will increase your left ventricular outflow tract obstruction. So metoprolol is the drug of choice. Uptitrate to bring the heart rate between 50 to 60. If the patient has contraindication to beta blocker, you can give verapamil. Diisopyramide is another drug which I have really seen underutilized. Less than 1 prescription in 10 HCM are on diisopyramide. Norpes is the most common trade name. It's an Gujarat-based company. Only 100 milligram tablets are available. You start with twice a day. The important aspect when you start diisopyramide is the patient should already be on beta blocker, because diisopyramide increases AV conduction and it can be pro-arrhythmic. So uptitrate the dose of beta blocker to maximum you can, and if the patient still has symptoms, you can add diisopyramide. Diuretics in a very small dose if there is chances of heart failure. A new drug which has come, mevacantam, it is not available in India, but it's available in black market. It is for 30 tablets they are charging 40,000 rupees. But that is one drug in future. It's a myosin, cardiac myosin inhibitor, and it will be available in India in a very short period of time. A recent study, that is in 2024 guidelines, they have added valsartan as treatment because it helps in preventing cardiac remodeling. Now, atrial fibrillation is something which is very underdiagnosed. Anticoagulation should be given to all patients, and rhythm control should be preferred. Invasive procedures, the patient is a candidate for surgical myomectomy if they fulfill these criteria. Another aspect is alcohol septal ablation. And the most important I wanted to put across is prevention of sudden cardiac death. So which are the patients who you would select for AICD implantation? Just 30 seconds, sir. Secondary, any patient who has cardiac arrest or sustained VT, primary prevention, if the patient has a family history of sudden cardiac death, the patient has non-sustained ventricular tachycardia, so that is more than 3 VPCs with heart rate more than 120. There is severity of LV wall thickness, unexplained syncope, more than 15% fibrosis on cardiac MRI, any form of LV dysfunction, and hypotensive response on exercise. These are the patients who are at high risk of sudden cardiac death. AICD should be offered to them, ICDs. Single chamber is good enough. Dual chamber only if the patient has AV nodal defect or persistent AF, and CRT if there is LV dysfunction. Thank you so much.